Okay, so I told him we're
Well, that
doing.
first part was boring.
Oh my god.
We're gonna make it better in this one. It's gonna be fine.
Everything is fine. I think you
Okay.
guys did great.
Hello, everyone, and welcome to the show. I'm Blair.
And I'm Kirsten, and we are mediocre content. And welcome back for us, because we haven't seen or heard from each other in about a month.
Yeah, it's been a long time.
Very long time. Glad to be back.
Oh my gosh, yes. This is definitely needed in my weekly life.
Yeah. So, we do have a bit of news. You have a lot of news to share.
I did a lot during the break. Yeah. Yes, there's a lot happening. And we just wanted to do a little bit of housekeeping. So we have one more show after this. It'll be our Christmas show. And then we're going to do we think in the new year, we're going to try and make it like a New Year's resolution, if you will, to record every week. Yes. So we're going to have a show every week starting in January.
It's a lot. It'll be a lot.
Yeah. So we're gonna do a lot of pre-recording during December and hopefully start the new year off with a show every week.
Yeah, which is great because that means more for the listener to listen to and participate in. But also more time for us to connect, which is the root of this show anyway. Like that was the whole point we did it. So it just kind of contributes to both for both of us.
Yes. Also, we're a goal of ours. We know you love the ad with our husbands. We're totally aware that you love it. And we're going to try and switch it up and do some other ones, maybe record a couple different ones just to like mix it up every week. Yeah. So yeah, that's coming in the new year. So stay tuned for that.
Be more work for them than us on that one.
Yes, definitely.
The point.
Definitely.
So,
and then we also might try and have some more guests. We do have a guest today. Yes. He's a surprise guest.
One of the mediocre husbands.
Yeah.
Everybody welcome Tyler to the show.
Yes. Yay, Tyler. Applause.
You're not going to say anything? You can say something now.
I'm going to talk later.
Okay. Yeah. Okay. Yes. All right. So clearly he's enthusiastic to be here, everybody.
Yeah, so happy.
But hopefully in the new year we'll have some other guests and some fun things to do, and it's going to be a good time, so stick around.
And they'll have to, because to do it once a week means we need their support, and that also means we need your support. So feel free to continue to send us things that you'd want to listen to, or maybe some topic ideas or questions that you have from previous podcasts. We'd love to integrate those into all future ones.
Yeah, actually today's topic is a direct request from one of the listeners.
Indeed.
So super fun. All right. So during the break, I have a lot to talk to you about. Oh, yes, my God.
I have to know the tea first and foremost on the Harry Styles debacle, because I heard that did not go well or as planned.
Okay. So first of all, I apologize to my husband. This does not pertain to him. You cannot trust no man. Okay. You can Harold Styles canceled his concert. Canceled his concert. And just tell you, it was not like the day before. It was not even like 2 hours before. It was an hour before.
Oh, no.
An hour before.
Oh man. And you were in line, if I remember correctly, because you did send me a picture.
This is a sequence of events, right? This is a sequence of events. So my best friend Caroline and I, our thing is like, we don't hang out like normal people. We like go to concerts and try to get front row. Like that's our thing. We've been to many a BTS concert. And so this was our first Harry Styles concert. And we were like, okay, well, we want front row. And in this particular venue, the situation is you camp out the night before to get a wristband to save your place in line. So they hand out the wristbands at 9 a.m. the morning of the concert.
Which is just ridiculous to me. I could never.
I know. Just hang in there with me, okay? So they were camping out the night before and waiting for 9 a.m. so we can get in line to get our wristband to save our spot for the line for general admission later on in the day.
Right.
So then we can go home and shower and sleep and everything, right? And be like normal human people.
Right.
So we wait out the night before, which camping is like kind of a vibe. First of all, like people brought like full tents and like had a whole setup and we're like living basically on the side of the street for this thing. It was crazy. It was crazy. I know. And the parents were out there being supportive. Like shout out to Chris, who like literally brought us food in the morning and Starbucks and stuff. Like he was the real MVP of this trip. Like I don't think this could have happened without him. And so we're camping, everything's going well, the vibes are good, like people are nice, great, everything's good. We get in line, we get our wristband, no problem. We're like number 200 in line, something like that, which seems like a lot, but the stage is big, so I think that we feel pretty good about that's like a front row like barricade spot, right?
Sure.
So we go home, to the hotel, we shower, we get ready, outfits immaculate.
They did look good.
So I've never felt better. It was great. I was so proud of my outfit. We had like glitter and we were ready. We were ready for what this was going to be.
Of course. But
so we're in line and we're waiting. We spent I think like an hour in line because they have you get in line about an hour before they let you in. Right? So everybody's in their place. They're checking, making sure everyone's in order, blah blah blah. And it's weird because there's like, so we're about to go through the metal detectors and there's security that's like on the outside trying to, well, we don't know what they're doing. We don't know what the holdup is. Like it's about time to go in and they're just standing there. And we're like, what's going on? We don't know. And all of a sudden, like we're getting kind of suspicious. We're not really sure like what the vibe is, what's going on. And all of a sudden this girl is like, it's canceled. And we're like, what do you mean? And she's like, it's on Instagram.
Oh no, they didn't even announce it to you guys. It was on Instagram.
I know. And then like 5 minutes later, this guy comes out with a megaphone and is like, we're going to have to ask you guys to leave.
Oh my
It's canceled. And Harold had the flu, so I can't fault him for that. It's fine. But damn, you should have known you had the flu at like 9 in the morning.
Exactly. That's exactly what I was just about to say, because there's no way that you aren't feeling bad before everybody gets there and you're like, ooh, maybe not like the best time for a concert.
Correct. That's and weird. There's evidence that the show before he had like a station where he was like had tea and stuff on stage. So he was not feeling super great.
I know
a couple days before. So, and this is the first time he's had to cancel a show.
Yeah, I'm sure he felt bad also.
Yes.
Yeah.
So I have theories. We have theories because obviously like as a sane, normal person, you would know like the morning of, and maybe he was really trying to like push through or whatever. And that's fine. But aside from that, I think maybe he was waiting for like a COVID test to come back. Just to make sure. Don't give me that look, Tyler. I see you in the background.
What a 15-minute COVID test.
Send
this off to the FBI or something?
Right. Yeah, I don't know. I don't know. I don't know.
To give him that room.
It's a working theory. Okay. And then I think maybe he said in his statement, like he just got back from the doctor or like something like that. But I'm like, you don't need a doctor to tell you can't go on stage because you're sick. So I don't know.
Yeah.
I don't know. So long story short, they rescheduled the dates for January, which is terrible because it's going to be cold.
Yes, exactly. Because
my wristband does not, it's in LA, but it still gets cold at night. Like it was cold when we were there.
I'm sure. Yeah.
In November.
Probably like 50s. Right.
Okay.
The sad.
It was like 45. Thank you very much.
That is pretty chilly.
It was cold and there's no like humidity or like any kind of it's just dry and cold. Okay.
Right. Yeah. But your wristband situation.
So the wristband situation doesn't hold up either. So you have to like go through the whole thing again.
That's unfair.
I know.
That's
I know.
kind of
so
unfair.
We put in all this effort
for nothing.
To like, yeah, for basically nothing.
Oh,
which it was. If I'm being an optimistic person, and it was very nice to spend time with Caroline. We had a lovely time. Did it end the way that I thought it was going to? No,
obviously not. No, but I would have honored the wristbands. Like if you're already in line and everybody was already there just about to enter for the real concert and they went through all of that trouble, absolutely honor the wristbands. That's absurd.
Yeah. I know. And I still have mine just in case they like come back and say like, oh, well, actually you guys can like, use these. Then I'll be like, great, easy. But I don't think they will.
Maybe they figure that people would probably just dispose of them, and maybe that's why they're like, people are probably just gonna chuck them. And so
I don't know.
I don't know.
I feel like some people wear their wristbands for like days afterwards.
It would not surprise me when it comes to Harold.
I know. So anyway, we're just.
It's okay. You did have one concert that went well though, right? Because you saw Lizzo like a weekend after. Yeah.
So the weekend after we went up to San Francisco, which is a lovely city. I do like it. It's expensive as hell, but it's it's like a fun place to visit. I think the vibes are cool there. Nice. But yes, we went to Lizzo, which was, you would have loved that concert. Oh my God. It was, she is just there to have a good time with everybody else. Like she is in it just to have a nice time with us. And I loved it. It was so good. We had like a Lizzo therapy moment where she was like, you guys are, she was like, have therapy with me. And we're like, great, we're having therapy now.
This is perfect.
It was a really good, she had a really good concert. She's really good. I highly recommend going to see her if you can. Those seats were not front row. Those were like nosebleed seats, and we had a blast. It was awesome.
So cool. Yeah, that's awesome. I'm glad you had at least one concert go well.
Yes. Oh my God. I know. It was also kind of nice because we went to the concert as like normal people, like not as like crazed fangirls,
Right.
And it was a very relaxing time. Like we got into the hotel and we like chilled and got ready, and it was just a chill, nice time, which we desperately needed after the weekend before. So
well, yeah, with all the disappointment and the questions and like
yeah.
I get that. Well, that's awesome.
So,
one
good.
for
all good things. All good
one
things.
for two. We'll clear up Harry in January. It'll be fine.
Oh my God. I don't know. It's exhausting just thinking about doing that again. Yeah. Like I was fully prepared for everything that was about to happen, and now I'm just like thinking about doing it again. I'm just like, I don't know. I don't know.
But at least the chances of him being sick twice, knock on wood, is like maybe
don't even put that out into the universe. Absolutely not.
Yeah. So you should be fine. Be good.
Yes. Yeah.
So do you want to jump into a disclaimer or two about this particular episode? Because it's a bit tricky for you two.
So right. So this episode is called Call the Medic, which I think is wildly inappropriate. And
I do what I can.
So I'm a nurse. We talked about this in a previous podcast. I'm a nurse in my day job. We're having Tyler on because he is also a registered nurse. And we're going to talk about like nursing and patients and, the whole medical healthcare experience that we've had. Right. So, first of all, we are not giving medical advice on this show.
Let's be very clear.
We're not doing it. We're not doctors. We don't, absolutely not. Okay. So don't take any of this as medical advice, because it's not. No. And the other thing is, we're going to be talking about patients, but we're going to be going by HIPAA guidelines and all that stuff. It's going to be great.
It's going to be fun.
It's going to be super fun. No names. And we're a place to like learn about things, but we also encourage you guys to do your own research. You guys know this if you've been listening to the pod. Tyler, do you have anything else to add?
Sure. So on the military side of it, I'm a naval officer, and as owned by the government, I what I state in this podcast and what I say is not the views of the government or the military or the Navy in particular. Um, they pay me a salary, and I try to serve my country as best I can. But in no way, shape, or form does this represent anything of the Navy or the big papa of the government. So
that's
please
right.
don't take it that way either.
He represents himself and himself only.
Love it. Yeah. Love that.
So
independent.
Yeah, you know.
Partly.
He's an independent woman. Don't need no man.
No man. That's right. That's right. All right, Kirsten, take us away with the good news.
Let's do it. So, since it is medical related, I figured it would only be correct to have medical related good news. So let's see. We've got CAR T cell therapy. This is chimeric antigen receptor T cells. These are special T cells as they're usually focused on for immunotherapies, and they've more recently been applied to lupus patients. So typically anything involving T cells has to do with cancer research. They've now expanded into these smaller trials with lupus patients. And the good news right up front is there has been a 100% success rate with the CAR T cells in their lupus patient trials. So
nice.
Yeah, so what they've done, there's 4 females and 1 male. All of them were diagnosed with untreatable lupus. And what they did is they gave infusions of these specific CAR T cells, hoping that they would go into remission. And they did, which, I kind of feel like never happens in medicine. That might be a little weird, but I feel like you do a lot of trial and error most times, and you just kind of figure out what sticks. And sometimes it's half and half, like, well, this works, but now they're experiencing this problem. So
right,
this is really good. So the way that these CAR T cells work in order to aid these patients is in a cancer cell, they're typically targeting the cancer cells themselves. However, in these trials, what they're doing is targeting defective autoantibody producing B cells. And then by depleting the B cells and allowing those cells to recover on their own naturally, I think they said it was about 4 months after receiving treatment, the B cells were no longer creating those autoantibodies in the patients.
Oh, cool.
Yeah. So basically, this is great for lupus, obviously, and great for lupus patients as the trials of other patients continues, but it's also good for other autoimmune diseases that are dependent on B cells, and they're hoping that they can use this study to branch out into things like rheumatoid arthritis or systemic sclerosis. Like, there's tons of other diseases that use these B cells that, could benefit from using the CAR T cells to treat them, which is great.
Nice. Oh yeah.
Do you know about CAR T cells in your research?
Not really. Yeah. I have not been privileged enough to be an oncology nurse, so I don't really know. I'm not familiar with a lot of the cancer stuff. I think the immune system is really fascinating, and I definitely feel like any progress we can make with autoimmune diseases, because there's so little options for patients now. I think progress is always a positive thing, for sure.
Exactly. I would agree. So moving into patients that may not even be born yet that are having issues. So there's obviously a lot of diseases that can happen in utero for babies. And then, of course, once they're born, they may be experiencing some things that they might not be able to treat in utero, and it's become a lot of problems. So they've got these pregnant mothers. Well, this one in particular is pregnant mother in Canada. Her unborn baby was diagnosed with Pompe disease, which I'd also never heard of before.
It rings a bell. Like, I feel like we covered it maybe briefly in nursing school or something, but I don't remember what it is.
Yeah, apparently it is a rare genetic disease that basically causes the baby's heart to become compounded with, I think it's glycogen, if I'm not mistaken. And basically, all it does is it builds up in the heart and makes it difficult for the blood to start pumping to their body. That muscle gets exhausted and then it can't carry out regular function. And it's really unfortunate because even though it is rare, it is almost 100% deadly to the infants that have it.
Yeah.
And I think sometimes they're born and they try to treat them after they're born with little success rate.
Sure.
But the good news comes because in this particular trial, what they decided to do was use a treatment through the umbilical vein. And
Nice.
the drug was called, and forgive me, I'm probably saying it wrong, alglucosidase alpha.
That
And
sounds about right.
I think I nailed it.
I think you nailed it.
I think I nailed it. But what they did is they used the umbilical cord's vein. They used 6 injections of this drug over a period of weeks. And the amazing thing is, not only did it appear to allow the birth to happen naturally with 0 complications, but the child itself did not exhibit any disease related to Pompe disease, and they're currently on track with normal developmental milestones as well. So
nice.
This is great news. This is amazing news because you're taking, babies that haven't even been born and allowing the treatment to go over and help them before they're even entering the world. So that's fantastic news.
Definitely ahead of the curve for sure.
Yeah, I can't imagine the stress. Having no children and not having been in that position, I can't imagine the stress of, going through childbirth and then also having the stress of your child having a disease and they're not even here yet. So this is great news for this particular disease and maybe other diseases like it. I'm not really sure if this can be used elsewhere, but maybe it can. So
yeah, I think it's interesting that they're using the umbilical cord as like a transportation for different treatments. I think that's really cool. And I don't know if that's like a normal practice with other things or if this is like the first time they've tried it, but it's a really smart idea because the baby's getting all their nutrients and everything through that anyway. So it totally makes sense.
Yeah. So I'm glad that they're doing it. I'm also glad that it's safe for both the baby and the mother because I'm sure that's a question every time you try something new, especially when it comes to, utero stuff and you're trying to
definitely
treat diseases that way. So I'm sure there's like a moment of, oh, is this going to be good or bad?
Right. Exactly.
So this is good. But my final piece of good news is kind of gross. So all of that.
I'm ready. Oh, so should we do the bodily fluid disclaimer right now?
If you're squeamish.
Okay.
Bodily fluids.
All right. So this is a podcast about medical things and we're nurses and Kirsten and there's gonna be we're gonna talk about bodily fluids. So I would just go ahead and say don't listen to this while you're eating. I think that's a reasonable for most people. They can't handle that. Just be aware we're going to be talking about human feces and blood and spit and gross things. Delicious. So just get ready for it. All right.
I feel like we're starting off pretty easy with a poop conversation.
Yes. Go for it, Kirsten. Yes.
Okay. So the FDA has recently approved a procedure that is called a gut microbiota transplant or fecal matter transplant.
I've heard of this.
It is exactly what you think it is.
Oh yeah, it is.
But this is actually in light of something that we have actually talked about on a previous podcast called superbugs. I would like to reiterate, these are not bugs and capes. These are diseases that have become antibiotic resistant.
Dun, da, da, da.
Yeah, they're so great. No, they're so terrible. And these particular superbugs in the gut have to do with Clostridium difficile. I'm assuming it's cele, but
so
yeah.
In the medical field, we call this C. diff, and we hate it.
It's and literally terrible.
It's disgusting. It's not cute at all for anybody involved.
As it's also not cute, it also causes like 30,000 deaths a year in the United States. It's gross and also deadly to many patients. And it's because it's a superbug. So it's very antibiotic resistant. I'm assuming it's painful, I guess, at some point, or
So the patients that I've had that have this, so first of all, you get this more than likely, and Tyler, like chime in if you want. You get this if you have a lot of antibiotics and you've depleted your body's ability to like have any good bacteria in your gut, right? And so then that what results is like a ton of diarrhea is basically what it is. And a lot of people don't know that they have it, which is why I'm assuming it causes a lot of like deaths, because people don't know that they have it, because a common side effect of, you know, antibiotics is diarrhea. Absolutely. So they don't understand. So when in the hospital, when we get people who have it, it's a huge deal. Mostly because I think it can sometimes be a hospital acquired infection just because we have you on a lot of high powered antibiotics. Right. But yeah, so as far as I know, it's not painful. It's just like really annoying and gross.
And I'm sure whenever you have something like that, it can cause, I'm sure, dehydration as well, because you're constantly having to go and
correct.
You know, replenishing is probably difficult in a hospital setting. You're stressed and things like that. I'm sure they've got IVs, but
yeah,
still,
it's difficult.
It creates its own problem almost in that setting. So but the good news is they have recently, and I say the FDA recently approved a procedure that would basically take a fecal sample from the gut of somebody that has healthy gut microbiota, and they would transfer those microbes to the affected person. This is done via enema. And while the previous studies that they've done have been in mice, they have been successful. And so what they're hoping to do with the FDA approval is to take this into obviously a human environment, standardize a treatment process to obviously treat C. diff patients and potentially other gut-related disease. So there's IBS. I'm sure Crohn's might be on the list.
It
UC
is
on the list. I know I have UC, so if there's ways to help the gut. I've actually heard recently, like within the last couple of months, I think it might have been another podcast, but they were talking about uh, obesity. Weirdly enough, I know it's a difficult topic these days. I mean, everybody has their own views on, bodies and things like that, but there is a there's medical reasons in some cases that somebody cannot lose weight. And what they're finding is by studying the microbiota in someone who may be on the morbidly obese scale versus somebody who's considered, quote, healthy in the gut, there is a stark difference between their microbiota, and they might be able to use this transplant process to reset the microbiota of someone who's having difficulty losing the weight. So yes, this is great news.
it really is. It's good news. Yeah. And honestly, this is the more extreme end. I just recently, actually, weirdly enough, I just finished a book called The Good Gut. Ooh. And it's written by two PhDs in like gut health, basically. Okay. And they talk about like the ways that in America, we don't necessarily have the best gut health. Sure. And the bacteria, good and bad, that are in your gut really determines a lot of like your health and your body's responses to things and your weight and like all kinds of different things that we didn't really associate with that for a long time. So this is like fairly new science, but like the biggest thing is they recommend, take your probiotics, eat a lot of fiber, have like good dietary practices, and it'll help you overall in your health. Like,
right. And maybe if you are having difficulties, maybe this new thing with, the transplant, maybe that becomes an option for people who are just really struggling and can't seem to do it with over-the-counter things.
Definitely.
So this is good stuff.
Yeah.
That's all I have for good news this time.
Cool. I thought I like your good news.
Thanks. It's literally all medical, so okay, this is all I can contribute.
Yeah,
not in the medical world. I'll just look up other people's contribution.
I love it. No, it's wonderful. Yeah, it's wonderful. So we'll jump into the first half of this podcast now. So Tyler and I will give our background of like what we do. Tyler, do you want to go first and like start from when you graduated school and then all your nursing jobs from there?
Okay. So I graduated Lynchburg College, now Lynchburg University, in 2016, and before I joined, joined and got into Officer Development School. I had a summer job, kind of waiting for that transition, and I was at a Episcopal Church camp nurse,
Nice.
and it was kind of overwhelming. I had 200 plus children from 12 and under, plus probably about 30 or 40 staff members. Um, I had the highest nursing license insurance that I could possibly buy.
Yeah, no, that's good. That's good.
First gig, gotta protect yourself.
But it was a great experience, needless to say. And so I did that for a few weeks, and then got the phone call to go to training. Nice. And start the Navy career. Nice. So did officer development school for 5 weeks, learned basic officership of how to be in the military, what to dress, what all that stuff.
Sure.
And then went to Walter Reed National Military Medical Center from September 2016 through August 2019.
Yeah. And what patient populations did you work with there?
So a vast first year was doing pediatric nursing, kind of cut my teeth there, as I say. And then they have a pretty good program there. When you're a new nurse, you kind of bounce from unit to unit for the first like 6 months, trying to just kind of get your range of clinical skills and knowledge. Cool. Yeah, it was kind of cool. And then you settled in one spot, so did the peds nursing for a year, and then went to a medical surgery neurologic unit, or the neuro unit, and kind of did a range of post surgical stroke, seizures, that kind of thing. We're the only, from what I know now, we're the only where you do video EEGs, so video electro whatever.
So EEG, for those who are not aware, isn't that kind of like brain mapping, sort of? You wear like the helmet with all the leads on it.
Yep. And so you can see your brain waves and see if you're having a seizure. They all sync up, and your brain kind of goes through these motions of electrical activity. Cool. So I think we had about 2 or 3 rooms that we could set up to do that, and we were the only military medical facility that does that. Cool. So we get patients all across the world that may or may not have seizures, and they're beneficiaries. So that was kind of, our unit was kind of set up for that. And then we did some distinguished visitors, which I won't kind of get into, but we did
fancy kind of military people.
Yeah, fancy military, or congressional government people as well.
Yeah, because Walter Reed is in Maryland, so it's like really close to DC.
Yep. So we took care of some pretty famous and very prestigious, honorable people, and their family members as well. So looking back at it, was kind of cool in that part. And then got out of Walter Reed, went to Pensacola, Florida, and was a ambulatory procedure unit, post anesthesia care unit, and
that's what I'm doing. Yeah, super fun.
And we did sedation work for colonoscopies and dental procedures as well. So we had an endoscopy suite as well. So
nice.
It's kind of like 4 units all in one, and it was pretty cool. And then after there, left Pensacola and went back to officer development school as an instructor. So now I'm on the flip side of that coin, 6-7 years later, to train new staff corps and new officers coming in.
So everybody that you're training is like a medical professional already, right? And then they go into the military.
That's most of the students. We do have engineers, we do have cyber crypto people, we have industrial hygienists.
Cool.
You kind of name it, we have it in some aspects. We have people coming from different branches, people coming from being enlisted to officers. So
nice. Okay, so it's kind of a mixed bag.
Most of them have military or medical experience, but it's a range. Yeah.
Cool. Yeah. Cool. Awesome.
And you do something a little bit similar, at least for one of those. You do the after surgery care, right?
Yeah. So my nursing career is much shorter than Tyler's because I got a full degree in chemistry before I decided I wanted to be a nurse because I thought I was going to be a doctor. It's a whole thing. We'll get into it later. But I graduated nursing school in May of 2020. So like 2 months after the pandemic started, basically.
Great timing.
Super fun. Love that for me. And I started on a med-surg orthopedic trauma unit. So we got, what I tell people is we got a lot of old little ladies that broke their hip and we got a lot of gunshot wounds. And there's no in between.
Extremes.
Right. Yeah. But it was a really great first job. Shout out to orthopedic trauma at Riverside. And I had really good people like teaching me, and it was traumatic for sure. Because the pandemic was happening and we got floated to the COVID units and stuff. But it felt like we were a good crew. And then Chris got orders to come out to California. And so I recently started a job in a post anesthesia care unit as well. So, and we're outpatient facility. So, we get a lot of people who come in to get their tonsils out, like kids. We get people who need like minor knee surgeries, and just like if you have like a weird lump and you need to get it removed, they do that. It's just like a bunch of different things. So it's kind of cool.
Yeah. You get a lot of different experiences, it sounds like.
Yeah. This is my first time working with kids though, and it's interesting. It's real, especially when they come out of anesthesia. Like you're not really sure like what they're gonna do.
That's the fun part. Right. There's plenty of
like TikToks. Their whole beds are like padded, and you're just like, okay, we're bracing for impact.
I love it.
Definitely a ticking time bomb.
Oh yeah. And everyone's like
mothers and fathers into that bed with the children to stop them from hurting themselves.
Right. No, exactly. It's like you make sure that they're stable, you go get mom, and then you just hope they don't wake up until the very end.
That's great. I love that stress for you.
Yeah, it's great. It's super fun. But yeah, I like it. So let's see. Tyler, why did you want to become a nurse?
Why do
you can say the money? It's okay.
No, I mean, in the military, we do get paid pretty well as a nurse, compared to what we'd be doing in the civilian sector. But I think that comes with a lot of other different responsibilities that maybe the civilian population doesn't have to deal with. But I think it kind of goes back down to, growing up, my mom had breast cancer, and kind of we went through that whole process, and she was always a big advocate of just trying to take care of people that you love. And going through college, I originally wanted to be an X-ray tech. Nice. Community college, they had an X-ray tech program, and generally had to apply to it twice, and I applied to it once, didn't get picked up, but it was either doing another year of community college or taking all the classes of what a pre-med or pre-nursing program would do, and then going to a regular university and nursing degree. And I just kind of thought, okay, well, seeing what the X-ray techs do, I've shadowed them several times, and if there's ways to move up in the X-ray world, but generally you start in a dark room, and you sit there for 5 years or more trying to move up to CT or MRI or ultrasound. I just didn't know what I could do from there of really trying to hands-on for patient care.
Yeah.
And I already had all the classes, I had the knowledge, and I was just kind of willing to jump and go for the whole bachelor degree, and I didn't know if I was really going to make it. So,
but do you think that you made the right choice moving away from X-ray and just going into full-blown nursing?
um, I don't think there's a wrong choice. I mean, X-ray tech world, um, it's really good. Those people are really smart. They know their stuff, and they're usually a great group of people that I've seen. It's just a different pathway. I don't think there's a right or wrong way about it. I think going nursing world led me to do my other dream, which was join the Navy and be a naval officer. And I couldn't do that as an X-ray tech because being a naval officer, you have to have a bachelor's degree.
Sure.
So
that makes sense.
There's other ways of being in the X-ray world and doing that kind of work in the Navy, but it's a little bit longer process anyway. So
what about you, Blair? What's your foundation, for deciding on nursing? I mean, you said that you were thinking of doing something else, but ended up doing this instead. So what was your thought process?
Yeah. So, initially going into college, like I'd always known that I wanted to be in the medical field. Like that was definitely something. And like, honestly, I'm not even going to lie, Grey's Anatomy, like had a little bit of an impact there, even though it's totally unrealistic and doctors would never do what those doctors do. I during that time, I was like, oh, this looks like fun. Like, I want to help people. I want to impact people's lives. I want to meet people where they are and just like, and make sure that they're not having a terrible time. Like that was like the motivation. And originally I wanted to be a doctor, which, I was 20 in college and I didn't really realize I didn't know the full impact of like the amount of schooling and the just like it's so competitive, and expensive. Right.
Very
exactly.
Expensive. Yeah.
Exactly. So then my brain was like, okay, well, I can fix this. I can be a PA. Let me be a PA. And so I actually graduated and got like a job as a nursing assistant while I was waiting to hear back from PA schools and stuff, and none of them wanted me because again, it's also like super competitive. And my grades just weren't like where they needed to be. Like they were good, but they weren't expert level,
Sure.
So so then I was kind of like, okay, well, I need to get a job, like a real job that pays real money so that I can move out of my parents' house. Yeah. So I was like, okay, well, I have all the classes. I have more than enough schooling for nursing school. Let me just do that. And so I applied to nursing school, got in, and then the rest is history. And I'm actually like really happy that it worked out that way. I think it all worked out the way that it was supposed to.
Yeah.
Because I hate the amount of time that doctors and PAs have to spend with, like, they spend no time with their patients.
Yeah.
And it's not their fault, and it's definitely not, it's they care, they do, but it's just the way that it is and like the way that their job is structured. And I would much rather be at a nursing level and really like know what's going on,
Sure.
and like have that time with my patients to make them feel better and like talk about their problems and like better treat them.
And would you say that that's kind of like one of your favorite parts of being a nurse, or do you have other aspects that you like more? Like, what do you like? What do you like?
So I love being a nurse. It's kind of a love-hate relationship sometimes.
Absolutely.
But I think my favorite part is just like when there's this feeling that you get when you've educated your patient, you've said, this is what you need to do to get better. And I'm sending you out into the world and like, you can do it. Like, I know that you can, like, if somebody comes in with like a broken leg or whatever, and they've got all their bandages, they're all set, you've done everything you can to like help them, and now they're like ready. They feel confident and they're ready to like make themselves better. It's like such a good feeling. The other thing I really like, and this is a little bit more specific, is I really like putting in IVs.
That's gross. I didn't hear that from you.
Love putting in IVs.
You know how I feel about needles.
It's my favorite thing. And when everyone else can't get the IV and I get the IV,
you feel like a winner.
It is unparalleled. It's like winning a soccer game and you hit like the winning goal or something like that, or you could kick the winning goal. It's unparalleled. It's so good. It's everything.
Do you agree with this sentiment, Tyler?
Yeah, I mean, IVs are a really good tool for us to administer medication and keep people hydrated. It's really, really important that some patients get a critical IV, and when there's certain nurses on your floor that can get IVs, they're a huge help to the team and critical for that patient. I trained on doing ultrasound IVs.
I almost did that, but we had to move. But I wanted to do that.
So ultrasound IV, it's basically the same tool that we use to look at babies in womb, and we can see your vein open and close and where that kind of tracks. And we put a really long needle into your arm.
Just so you know, Kirsten is gagging. She is not having a good time.
Keep going.
We'll put it in your like bicep or foot sometimes, not in ultrasound usually, but
I mean, it's been done.
Wrists, wherever you can, and it's really cool to see the needle pick up on the ultrasound and go into the vein. And for Kirsten's freaking out, but in the hospital setting, if you can get an ultrasound IV, it's good. It's in the vein. It's going to be there longer. And that's even better than what we call like a blind stick or just a peripheral IV. Now you have an ultrasound deep vein that's going to last a lot longer for the patient. And
and it's good for patients that don't have any veins left, because people stay in the hospital for a long time sometimes, and after you get stuck many times, it gets to be very terrible for the patient, and you don't have anywhere else to go. So ultrasound is a really like important tool for sure.
Especially for the population that we're getting in, and I haven't been in the hospital for about a year and a half now, but populations that we're getting in are a little bit, what we say, fluffier, larger set people.
True.
And it's much more difficult to get a peripheral IV on those people. Their veins are just deep, and you can't reach them with a normal stick. So
your needle's not long enough sometimes.
And I can honestly say, I'm gagging aside because just the image makes me queasy. So for all the other squeamish people listening to the podcast, still good for you. We are holding it together. But I can attest to having a good nurse. Having had to do many procedures over the years, I have had the worst, and I have had the best. And I can honestly say the best make a world of difference when you as a patient are already going through anxiety about being there in the first place, and then also knowing that you're about to have a meltdown because I've had experiences where I've had to be stuck 6 times before somebody got it. And it's traumatic for everyone. So
I feel like a lot of people have those stories. And I get like a lot of my patients now, haven't had to get IVs very often. And when they have, it's been a story like that where it's like, oh, I got stuck like 8 times and it was terrible. And I'm like, okay, well, this is the deal I'm going to make you right now. Is I'm going to look and see if you have any good veins. And if I physically cannot see any veins on your arm after I have like tapped you and like put the tourniquet on and warmed your hand and like all of my little tricks, then I will not stick you and I will find somebody else. And other than that, I'm only going to stick you twice.
Exactly.
That's the deal. And then you move on to somebody else. But like,
that's a pretty good rule to follow.
I think it calms people down because I feel like sometimes people feel like pin cushions, and I don't want you to feel like a pin cushion.
I definitely did that day.
Yeah. Yeah.
There was definitely a moment where I remember they brought in the nurse that's been there since the 80s and like lives and breathes the hospital, and she saunters in and I'm like, where were you like 26 ago?
Right.
Right. And she like walked in. I was like this close to like just saying, just go get my husband, he can probably do it faster. But she walked in and she was like, having a rough day. And I was like, yeah, I'm having a really rough day. And she just talked to me. And by the time she finished the conversation, the needle had been in for like 3 minutes and it like instantly fixed everything.
We love that. We love that.
And with your IV sticks and your new pediatric patients that you have, how are you dealing with the family members and the parents on that one?
So we actually are fortunate enough where we don't put in IVs on anyone like younger than 5. We have the anesthesiologists do it. They'll like do it after they're out in the OR.
Oh, okay. That makes sense.
Because it's outpatient. We don't want to cause any other like more trauma than there's already going to be. You know, they're in a medical setting. So we typically, after they've been out for a while, anesthesia will do it, which is nice.
That's really nice. Yeah.
Yeah. A little bougie, to be honest, but
kinda. But, hey, you know, whatever works.
I mean, yeah, honestly. And sometimes, like, depending on like if they're just getting tubes put in, usually they just use gas anyway, and they don't need an IV, you know.
That's nice.
Yeah. So with that though, between the two of you, do you guys prefer hospital work or do you prefer having the outpatient work? Like, whoever wants to chime in.
Tyler, you can go first.
It's hard to say because there's pros and cons in either one of them.
Sure.
I agree.
But
I agree.
The outpatient's a little nice just because you know, you're not having to bring in another set of staff members to come in and like relieve you for the day, or maybe you're the night shift staff member that's coming in.
Right.
But you know, hospital side, you actually get to develop a really good relationship with some of your patients. Because you spend days on, weeks on, months on sometimes with these patients. So it's difficult to say. I mean, it just kind of depends on the nurse and what your style is. You know, if you like your weekends and holidays, then you're probably gonna like the outpatient side.
Right. Yeah. So for the listener who is not fully aware, patient is like 9 to 5. You get all your weekends and holidays off. It's like, you know, any regular job. And then in the hospital setting, it's usually 12-hour shifts. Some hospitals are more flexible than that, but usually it's 12-hour shifts and you work 3 days a week, which sounds lovely. But let me tell you, if you don't know what nurse hangover is, it's like being hungover without drinking anything. It's awful.
Especially if you do like night shifts.
That's only 3 days a week, but like how many times out of that week do you get a call to come in and work an extra shift or pick up something? So I'd never guarantee 3 days a week. That's huge misconception. Oh, like you only work 3 days a week. Well, no, I work actually like 5.
Well, and the other thing is like you don't necessarily work your 3 days in a row and then you're done off for 4 days. Usually it's like 1 day on, 1 day off, 1 day on, 1 day off, or it's like 2 days in a row and then you have a day off and then you're working 2 more days or like whatever it is, you know, it's weird. Yeah. And I think I like both, like you do, Tyler. I think I like the hospital setting is nice because you do get those patient relationships. I think it's easier to get burnt out in a hospital setting. And I think that you really have to be conscious and take care of yourself in order to do that for a long period of time, especially in this like post-COVID world we're living in. But like I could see myself doing PACU like post anesthesia for like years and years and years and like never feeling like it's awful or I need to take a break or anything like that. Cause you know, you have your time off.
Yeah,
you know?
I completely agree. If you want your skills to develop as a medical provider, then the hospital is it. But if you want to save your back and have a more balanced lifestyle, especially as you get older, as a medical provider, then outpatient's the way to go.
Yeah. And that's the other thing.
That's in my opinion.
And I miss the hospital because I feel like you on the daily you get more like cool things and you learn more, and it's like a more stimulating environment. But also I definitely, after just working 2 years in the hospital, I felt really burnt out afterwards. Like I was ready to take a little break. It was a lot.
Sounds like a lot.
Yeah. So yeah,
I give it up to those nurses that do that, like hospital life for
I know
30-40 years.
Well,
I don't know how they do it.
I would talk to these older nurses on my unit who, had been there since the dawn of time or whatever. And they were like, it didn't used to be like this. It used to be more fun and cool. And it didn't. And like, honestly, and this is maybe controversial, I'm not sure, but I really feel like the hospital business model now is like burn people out so you don't have longevity in your nursing staff, and then because it's cheaper, it's cheaper to hire travelers. You don't have to give them benefits. It's cheaper to hire new grads because they're they don't have any skills or knowledge. They just need a job. And so then it doesn't really matter what happens to them 2 years down the road. So you just keep hiring those turnover people, and you don't develop any kind of like culture, and patient care goes down and outcome goes down, and it's like a whole thing. So, and I just feel like that's really not a productive way to run hospitals, but that's just my opinion.
Well, I mean, and two, it's population as well. If I remember correctly, I saw in the news, I think last week, that we have now tipped over into the 8 category. We're not at 7 billion. We're at 8 million people now. And I'm sure cities have become more densely populated. People are finding it harder to, find spaces that aren't occupied on the planet. So if you're looking at it from that perspective as well, we as a population have also grown. And of course, what happens when you have more people? You probably have more people that are sick, and there's more people encountering sick people who are now also sick.
Right.
So,
and the older generation is like the biggest generation we've seen so far.
Yeah.
Exactly. And then our generation is going to be another really big generation. So we're going to have to like figure out how to equip medical facilities for this. It's so. And anyway, not to be a drag, but like
there's been epidemics, obviously, as well, that has probably influenced that and greatly. So, COVID's a big factor.
All I'm saying is, if you want your nurse to like be stick you the first time, encourage your hospitals to like keep nurses on for more than 2 years. That's all I'm saying.
Yeah, exactly.
All right. Do we want to take a break? I feel like we've been talking for a little bit.
Yeah, let's take a little break, and then we'll bring it back and give you more of the nursing goodness.
Yay!
Hey, we're the husbands of mediocre content. Bringing you an ad segment that's missing, an ad.
This is a break brought to you by us because we're the only ones crazy enough to sponsor this thing.
If you'd be interested in sponsoring the Mediocre Content Podcast,
and we understand if you aren't,
contact our mediocre wives at mediocrecontentpodcast@gmail.com.
For now, enjoy this brief break from the podcast before we throw you back into more unimportant,
dare we say, mediocre content.
Welcome back, everybody. We hope you had a good break. We are back at it with our 2 nursing specialists over here who are so knowledgeable and have so much experience. And we're going to talk about some favorites and least favorites. And let's just get started. Let's go to Blair. We've got your favorite patient and your least favorite patient and the big old why.
Okay. So I thought when I was typing this episode out, I thought about it a lot, and
Mm-hmm.
I have a few favorite patients, and the characteristics of my favorite patients were the ones that I would walk into the room and they just make me feel very like they're they want to make sure that I'm okay, which is very nice.
Yeah, that is nice.
They Tyler, what are you doing?
We're making sure our stories are appropriate.
Oh,
anyway,
got it.
Continue.
Got it. So one lady, she was like best friends with all of us on the unit, and we would all like talk about her like she was part of the staff. Oh, and she's just she like broke her leg or something like that. I know, but she was with us for a while because she had to do like a bunch of traction and a couple of like she had a big X fix, so like an external fixator for people who don't know what that is. It's basically when they put metal bars through your leg. Ugh. And then it on the inside it's like holding your bone together so it can heal. And then you have it on for however long the surgeon wants it on, and then they take it off. That's and delightful. Put a cast on, and it's an experience.
That's an understatement.
Anyway. Yeah. So she was with us for a little while, and then she came back to get her X-Fix taken out. And but yeah, she was super great. And she was like, you guys, I'm gonna have a party and we're all gonna like go over to my house and it's gonna be super great. And she just like loved all of us, and just going in her room was like a ray of sunshine. It was wonderful.
Can I just clarify, this person left with metal rods stuck in their leg?
Yeah, so they don't leave. So they don't necessarily go home. Sometimes they do, but they usually go to like a rehab facility where they do like physical therapy and stuff.
Okay. She just walking around.
Yeah, sorry. I should have clarified. No, most of the time they go to like a place where they do a lot of physical therapy, and then they come back. So that way they're not like sitting at home just like, not taking care of their leg and everything. So and then I also had another patient who, this is kind of gross. He was a favorite patient of mine, and he so he is a police officer in his day job, but he got this accident by like falling off of he was cutting trees and like fell. And yeah, so he was up really high and he fell, and he like landed on a branch and it like ripped from this is I don't know if I should say this, maybe not.
Please don't.
Anyway, he sustained some really bad injuries, right? And so he was in the hospital with us for like 40 days or something like that. And he with the wound care clinic and the doctors who helped, the orthopedic surgeons who helped mend all of his bones, and the wound care clinic people, he was able to make a full recovery. And he visited us on the unit like 3 months later, and was like walking and running and like doing everything that he would normally do. But he was really broken when we first admitted him. But he was such a nice guy, and his wife was so nice, and everybody, and he just had like he was willing to do the work to like get to make his recovery good and make it quick. And he did so well. And it's just so easy to have patients who are like willing to like heal themselves or like do what they need to do in order to make it happen. It's like it makes our jobs much easier. So,
but there are a few perhaps that do not do that. Do you have any least favorite incidences perhaps?
So I'm gonna say typically the ones that I like the least are surprisingly not the grumpy old men. I am a grumpy old man whisperer. Like they like me for some reason. Nice. And however, it is the ones that bring drugs and guns and like things into the hospital that they're not supposed to bring. And they have people who are like funneling extra medications to them and things like that. That happened in my like one time we had a patient who ordered McDonald's and his friend like brought it to him, but his friend didn't come inside. He just left it at the front desk. And so we went down and got it, and we like checked before, and there was drugs in it. What? There was drugs in the McDonald's.
I wonder if that was extra.
That's great.
How so much like extra those did they have to pay for that? For McDonald's.
$50 for cocaine in your burger.
Would you like a toy with your meal?
Oh God.
Well,
but like
those
like
what
and
Uber
like
was doing, or like not Uber, but like what a lot of those delivery driver, food vendors were doing, right?
Oh, really?
In the middle of the pandemic, like people couldn't get out and get their drugs.
Oh.
They were delivering their drugs.
Yeah.
Not all of them.
I don't know. No, but I'm talking about, I'm not talking about prescription drugs. I'm talking like hard drugs.
No,
like,
that's what I mean. Yeah.
Yeah.
That's
like people were getting delivery weed through like DoorDash.
I wonder if that was also extra.
Like you tip the driver much, you can get whatever you want, I guess.
I don't know. But like those patients, and like one time we found like bullets and a knife and like all kinds of other stuff like in this guy's cabinet in his room. And at the outpatient center, there was a patient who brought a gun in his like jacket pocket, and he wasn't going to do anything with it. He was just like someone who had a concealed carry or whatever, and like wanted, but he didn't tell anybody about it. And we're like, I like picked up his jacket and brought it into the room, not knowing that there was like a gun in there.
Meanwhile, Blair's just like, da da da.
Get his Percocet
and he like freaked out. He freaked out that like I touched his stuff. He was being really weird about it, and I'm just like, bro, if you just told us that you had a gun, we would not do anything about it. You know what I mean? Right. We just need to know. So those patients are the ones that are my least favorite because it poses a safety problem for me and the people around me. We're just trying to help these people out. We're not really trying. I'm not trying to like catch a drug charge or anything at work. You know what I mean? I have stuff to do.
Yeah. No, that's
I don't know. So those are my least favorite patients, I feel like.
All right.
To keep it broad.
Yeah, that's pretty broad.
No drugs or guns around Blair.
Don't do that. All right, Tyler.
Not at work. I mean, Jesus.
What about you? You got a favorite or a least favorite, I guess. Yeah. What's your favorite?
Favorite or just people with a sense of humor? I think you can make me laugh while we're both of us going through a difficult time. That helps. Kind of. I don't know. Nurses have dark sense of humor anyway. And so
we do.
We appreciate when the patients have that similar dark sense of humor, or do some crazy stuff, and then we kind of laugh at it later.
Yeah, that's right. Yeah, sometimes. Yeah.
But like I have one family from a patient that passed away, and they years later now, and they still will send me emails once in a while or write me a card. And I when you can integrate into their family. Some of them called me, a redhead stepchild or whatever.
He's a redhead too, for the listener.
I think that, you have to appreciate that. You really make an impact on some of these people's lives for the rest of their life as a nurse or as somebody that's close to their family members. So, those are the ones that you kind of look back in your career, and you're able to kind of look fondly upon, but
least favorites.
Least favorite?
The opposite of the touchy-feely goodness.
So I'll do it in two parts, right? So first was pediatric patients. The kids are fantastic, right?
Yeah.
I don't think I've ever met a kid that I'm just like, I don't want to take care of them. But the families and the parents of some of these kids, and I thought I would never have to deal with because of the military side of the house, but they're still in the military. Like, you're still going to have people that abuse their kids. You're still going to have people that neglect their kids in the military.
Yeah.
And those people I despise, right? If you
That's
don't
fair.
There's so many ways to not have children nowadays. And for you to have a child and then you abuse them and neglect them, I just have no sympathy for. So that being said, some of those parents I couldn't really deal with.
Yeah, that's one of the reasons that I didn't initially go into pediatrics.
Yeah.
I can't do like mother baby stuff either for that reason. I would feel so terrible sending a baby home with their mom who's not, everybody knows is not willing to do anything for them.
Yeah.
Yeah, that makes
sense. And yeah, sometimes it's not even mom, is the whole family that's against that child or whatever it is. But you know, a lot of nurses don't want to go into pediatric nursing because they have to stick the children. They have to, you know, do things that make the child uncomfortable. I got over that pretty quickly, needless to say. You do have to stick these babies multiple times, you know, turn them into a pincushion if necessary to do the treatment. So,
but it's the outside factors,
right?
It's not the patient.
It's dealing with the families that are, and a lot of times in the military and the medical scene anyway, you might see that parents are not doing what they need to be doing, but there's nothing you can do, right? And that's
exactly
that's a secondary problem that I have. But the other part, my least favorite patients are one that are abusive to the nurses. So a lot of times as a male nurse, I would get called in and be like, hey, this patient's saying inappropriate comments to me, or they're yelling, cussing at me. Can you take them? Absolutely. I will take them from you. And the last thing a lot of these patients, female or male, would want is a male nurse a lot of times.
See, that's what always irks me about, like, I love the male nurses. Like, every male nurse I've ever worked with has been just the MVP. Like, it's wonderful, but it just bugs me as that, like, people automatically respect men more in those kind of situations, and it just bothers me. I don't think
know
that's
if they
fair.
respected me any more than a female. I just know that they wouldn't
well, they're not going to mess around
past me.
Right, exactly.
Their attitude would completely change when I walk in the room.
Exactly.
And you know, you don't want to piss off Tyler nurse in your room because you know, verbally assaulted one of my nurses. And when I say my nurse, like, a lot of times I'll be charge nursing her.
Sure. Yeah.
The senior nurse on deck. So, or
on
a corpsman,
deck, like you were on a ship,
like a corpsman of mine, right? Like,
you gotta say it like you're in the middle.
I was on a ship for a couple weeks, right?
Oh my god, on deck.
But
excuse me, sir, we're on land.
Here we go.
He gets confused.
But yeah, or you like mess with my corpsmen or medics, like the junior enlisted people that are really trying to help you. I have no sympathy for, and you are my my least favorite patients by far. I'll still take care of you, I'll still save your life, but
right, yeah.
But it's very I don't know, it's very annoying. And we had several patients that, you know, try to use their rank, especially retired rank. None of the active duty people or reservists would ever try to do this stuff, but once you retire, I don't know if you're still trying to feel like you're in the military, but you start using your rank, and then they expect some kind of certain privileges or certain customs and courtesies to still be rendered to them, and we play along, right? But I'm not going to treat you any different just because you're retired. Whatever.
Yeah.
So that bothers me a little less, but that still does play a part, especially.
I mean, we would get people who were in the military. I don't even know like what rank they were or whatever, and they would be like, "Well, you know, I deserve better care because of X, Y, and Z," or you know, somebody who was related distantly to somebody who was in the hospital administration or whatever would come in, and I mean, I like to think my standard of care is pretty high, like in general. But I'm not like, I don't really care like I'm gonna treat everybody the same.
I don't really get
you know, I don't.
Well, because your job is to fix whatever is going on in the environment and do everything that you can to meet the patient's needs so that they can be discharged and go out into the world and be healthy and live healthy lives. But your job is that's it. That's the baseline.
Right.
Make sure that you're healthy.
I'm gonna do a good job for my patient. Yeah.
Yeah, exactly.
Regardless, you don't have to tell me that you like know somebody. Like I was
gonna do it anyway.
Yeah, I'm gonna do it anyway. Like, don't worry. We can save this conversation. You don't need to. Yeah.
Now, with that, you had your favorite and your least favorite. What is the weirdest or maybe grossest thing you've ever had to do as a nurse thus far? Let's go, Blair. What you got? And also understand that I'm sensitive and there may be other sensitive people on the call.
Okay. Well,
are you struggling?
No, it's just like I'm just trying to I'm trying to tone it down a little bit, but I don't know. We'll see.
No, you know what? Never mind. Just go for broke. You're fine. Just let it loose.
Okay. Well, this is a weird thing. So I have had many patients, especially ones who have dementia and ones who are above the age of 70, do a lot of really weird things. But the weirdest thing, which it was a whole learning process for me when I became a nurse, is that people above the age of let's say 75, obsessed with pooping every day.
Oh, I love that.
Obsessed. For those who don't know, when you have surgery and you have anesthesia, it slows down your whole your body basically just goes to sleep. Sure. And so the last thing to wake up essentially is your bowels. So it is not abnormal for you to not poop for a couple of days after surgery. Okay. That's not an abnormal thing. And these old people are sitting out here. They're like, can I please have an enema? I haven't gone to the bathroom in 12 hours and I just need to go. Otherwise I'm just going to be, yeah.
I must have misinterpreted that.
I had a woman beg me for an enema, and a tap water enema where we're injecting water in her butt.
Trust, I've had one. It's not pleasant.
I got you.
And it's
Tyler says, bring it on.
Every old person is a lot of old people are like this. They have to go every day, or it's the world is ending.
You know what though? I would love to know if there are individuals who listen to the podcast who are within that age group. What's the obsession? What's got you bent? Are you concerned you'll never poop again?
Right.
Is there a medical reason that you are no, if I don't do it now, it will never happen again? I would just love to know, honestly.
I'm very nice about it. I'm very, this is normal. This is totally normal. I can get you a stool softener. I can get you some Miralax. I can, we don't need to immediately escalate to enema. I
just get it done.
Right.
What about you? You got any poop stories? Okay, I'll back up. Grossest, weirdest, coolest. What you got?
One other thing. Yeah. Have you ever had anyone ask you to warm up prune juice for them?
Yeah.
Ew.
Okay.
It's gross.
All right.
We used to do what is it? The Walter Reed we did prune champagne, which is warm prune juice and Sprite.
Ugh.
And then a little bit of Miralax in it. And
okay.
It worked wonders.
That's a great idea, actually.
Yeah. We used to mix all those medications together. Mag citrate.
Oh God, mag citrate is nasty.
It's the golden champagne of constipation right there.
The gold standard.
Mag citrate, get to go.
I know. So one other thing too, if to get somebody to pee, one of the nurses told me to give them tea with a little bit of sugar in it, and that usually gets people to pee. Why? I don't know why.
Sweet
I don't
tea.
know. Yeah,
I guess.
I don't, but it's warm. But
yeah, I've never had people I never had problems with people peeing as much as you
Really?
would think. Like,
Oh,
whether to catheter, like to do a
Yeah.
catheter or not.
Not as
Yeah.
much.
Maybe a few patients, but it wasn't really
Oh.
a
we got that all the time, especially
Really?
after surgery.
Yeah.
Yeah.
Huh.
You just wait them
I
out.
wonder. Just wait them out.
Not in my job now, but in the
Right.
hospital. In the
Right.
hospital
Right.
with the major surgeries and stuff.
Curious about the tea, honestly. Like,
Yeah, I don't know what that is, but she said it works a lot of the time.
Sure it does.
That's just like a little nurse hack. I don't know.
I'm sure it does. Or
Yeah.
yeah, that's weird.
Anyway,
I'll keep
fun
that in
fact.
mind in case I'm ever having issues. What you got for your grossest, weirdest, or coolest?
Yeah.
Mixture,
looking back at my notes from, because I write notes about like not patients' names or anything, but just funny stories from when I was like on the floor working in that and in the trench, as I would say.
The
I looked at this one that says marijuana HIV positive guy with neurocephalus running around swinging his urinal and trying to drink it.
No.
Laying on his back, butt ass naked, peeing in the air, trying to catch it in his mouth.
That is disgusting. Why would you make a note of that in your phone? You're like, I'm gonna need this for later.
And so I think this guy, he was one of the ones that we see all the time, but he got laced marijuana.
Oh no.
And he already had HIV.
Yeah.
And then he was having this neurocephalus, which makes basically like psychotic.
Yeah.
Being like hallucinations and all the other stuff. So
isn't that like water on the brain or something like that?
It's
or no? That's
inflammation.
Yeah, inflammation. Okay,
it's inflammation. And I remember coming in that shift, and my nurses were like, kind of shaking their head, like, "Oh, you got a good one tonight," and then this guy.
I love it when they do that. Everyone in day shift is just like, "Guess what we have for you."
Yeah. Well, because you're like coming in all fresh, and they've been, busting their butt for 12 hours.
Right.
Yeah,
Yeah.
You're waiting for that night shift to come in.
Oh yeah.
And then you're just like, feel the pain with me of what I've been doing. And then you come in the next day and then you see that on them. But I remember
like
this guy,
I told you they were crazy.
This guy like was trying to catch pee in his mouth. He felt that he dreamt that like he needed to that was the only way to hydrate himself or something. But then after, the bad part about it was after all the neurocephalus kind of calmed down, he didn't remember anything, and people were telling him like, "Hey, you were doing this, this, and this," and he was so embarrassed, and he was just beside himself. So it was funny at the time, but like afterwards, you kind of like, oh, yeah, it's kind of bad that like this guy's doing all this stuff and he doesn't even know it. So but it was funny at the time.
Well, you guys
I have had many a patient like pull out their Foley, like just
first of all, does that hurt though?
So what's a Foley?
You would think. Oh, okay.
Most people are not going to know what a Foley is, I'm sure.
A Foley is a catheter. And in order to insert the catheter and have it stay in, you insert the tube into the urethra and then blow up the balloon so that it stays in the bladder so that it doesn't slide back out.
Delicious.
And people with dementia who don't realize what they're doing, typically, they are like, oh, well, I have this tube that I don't need because I don't know what this is. I don't know where I am.
Right.
And they just pull it right out, balloon intact. And then there's blood everywhere and pee everywhere. And it's wild.
Oh my goodness. That is so terrible. Well, and
it's not
dementia
good.
is a terrible disease as it is. So it's just amplified.
Also, I will say the strongest people in the world, and I will go to the grave with this. The strongest, I will die on this hill. Okay. The strongest people in the world are 90-year-old women with dementia.
Oh, interesting. What's the basis? What you got?
I have had many of them hold my arm, like, and push me away so that I would not touch them and do all these things, even though I'm like trying to help them, right? Because they have like, right. But the combativeness is strong, and they will kick and fight and like all kinds of things.
Wow.
And they are just so strong.
Amazing.
So strong.
Wow.
Crazy.
That's kind of impressive at 90 also.
I
like, just
agree.
in general, truthfully.
I'm like, I'm pretty sure like on any other day you would think, you would look at them and be like, oh, like I could take them in a fight. No, you can't.
No. Just give up now. You don't have a chance.
Absolutely not. Absolutely not.
I think the grossest thing that I've ever had was I was helping this patient from the bed to the toilet, right? So it's a little bit of walk in between.
I feel like I know what
and most of the older patients have diarrhea anyway.
Mm-hmm.
So when we got to the toilet, he was already starting, right? And so it was all over the toilet seat. And I went to go across to grab some toilet paper to wipe the toilet seat, so that way it wouldn't sit in feces. And I'm like, okay, let me,
Tyler,
I'm gonna make sure this is good to go,
Tyler.
And luckily enough, I had, I already had my PPE. I had my PPE, my protective, personal protective equipment in my my glove.
No. Yeah.
And I went across, and he shit on my hand.
No.
Just laid a turd right on my back of my palm.
How delightful.
And at that moment, I paused.
Of course you did.
And I thought about my life. And I could feel the warmth in the back of my hand. And I just remember, like, what am I doing?
Oh my God.
And I remember him, like, he was kind of like, are you done doing whatever you're cleaning up? Like, he was yelling at me to hurry up.
Right, yeah.
And I'm like, hold on a second. I'm evaluating my life at the time.
I got a crisis going on. Oh my God.
And
I'm rethinking all of my life decisions up until this point.
Yeah. And I was thankful that I remember, as a nurse, you go through nursing school, they always say, first thing you do, go in a room, put your gloves on.
Yeah.
That's right.
Put your gloves on. Double up, put your gloves on. Whatever.
That's right.
And I know a lot of nurses get lazy, or they feel that they know better, whatever it is, and they don't put gloves on. And
no, you put your gloves on.
I remember putting my gloves on, and I was thankful that I put my gloves on. And
I think that's
yeah.
And it so happens like that. Like it happens.
Okay. But with that said, you guys have both been talking a lot about some kind of bodily fluids going on.
Yes.
What I need to know, what is the one bodily fluid you cannot stand? Like the one that will just turn you away immediately? Because it clearly ain't poo, considering both of you have quite the experience with it.
Spit.
So, really?
100%.
Why that?
100%. 1,000%.
Spit.
First of all, it's the human mouth is disgusting. All right. I was not a dentist for a reason. Okay. Second of all, if you have never had a patient that has had a trach, which is like, for those who don't know, it's basically another airway that if the patient can't breathe through their nose or mouth or whatever, and they need another airway, they just put a hole in your throat. And the secretions that develop there are truly vile. And if you cough and you have a trach, all of the secretions come out of it, and it like spews out into the room. And it's disgusting. It's not good. And like it's not good. Okay. It's not good. It's not good.
Blair says
the mucus plugs in there are great.
Yeah, it's the
mucus plug is like when you have that trach and it builds up all that gunk, and then they eventually cut it off, and you have to like save them by like, getting that mucus plug out of there.
Yeah, it's not good. And then the suctioning is just, I feel like I'm hurting them, even though
you are.
It's very uncomfortable for everyone.
How comfortable do you think it is to put like a little tube down someone's?
Probably not very comfortable at all. But it's either that or they aspirate on their secretions. So it's like, It's not great. I would rather clean up someone's poop like 1,000 times than have to deal with that.
What about you, though? You seem to disagree on the spit.
I can deal with mucus plugs and trach. Yeah, that's. I mean, it's okay. It's not the best, but it's all right. I think it's the ostomies, depending on where they're at.
Oh yeah.
So ostomy, for people that don't know, it's when they make a artificial exit of your either small bowels. Usually, it's in the small bowels. And your small intestines for whatever reason, and you have a bag that's associated with it. And depending on where that ostomy is, it depends on what comes out and what it looks like and smells like.
If it's more like liquidy and bile.
And those people are really, especially the ones that have it for a long time, they're really brave. And I don't know how I could deal with that. I mean, eventually you just get used to it, and you learn to deal with it in their own ways, because they're really finicky. The bags are really kind of finicky. They're getting better at it. Technology's getting better at it, but it's just a finicky process. But depending on where it's at, it's not really pleasant. I knew one nurse that was working with the distinguished visitor, and she went to go change it, and she was a relatively new nurse like me, and she opened the bag and that smell hit her, and she vomited into the bag, into the patient basically. And you know how upset as a patient was.
There's a lot of upset things
vomit into your ostomy.
No,
the worst.
How did that even work? Like, the bag usually points down. Like, was it off?
She was burping the bag.
Oh, okay.
So there's gases that build up in the bag, and sometimes you have to slightly open the bag to like release the gases. So you don't have to. And I think she was burping the bag, and that's what happened. So,
wow.
Yeah,
that's the one. Ish. Yeah.
It's either that, or you're talking about C. diff or something like that. C. diff has a particular smell.
It does.
That's associated with it. And if you're not used to it, that can really throw you off.
Any nurse who is any nurse who's been around for a little while knows there's a very distinct smell with C. diff, and if you've ever smelled it, you'll never forget. And so you'll be able to smell that your patient has C. diff way before anybody else knows. And it's not great. It's not a great smell. Smells don't really bother me that much, though.
That one's got like a really weird smell.
It does.
For feces and stuff.
But the good news is that might be solved based on the good news from the beginning. So maybe there'll be some trials to help eliminate that problem. So
it's going to be a problem. It's just a matter of treatment of that problem.
Right.
I mean, they've had treatment for C. diff for some time now of using
particular antibiotics.
They'll that's why they test for what bacteria is spreading or what substance you have or whatever it is.
Gotcha.
But they've used dehydrated good human feces and packed it into pills and used that, and that's been some pills for a while now that have been doing that.
That's why I was saying earlier, like, fecal transplants are very invasive and they don't always work. So I'm sure there's like a bunch of other things to try ahead of that. But it's always it's there for us if we need it.
Right. Well, on that disgusting note,
yay!
I honestly feel like that's we should just end it there. Just really,
you don't want to hear more about this?
Look, I just love that the image you guys have left them with is wrapped in poop, vomit, and spit. That's why we're ending this podcast.
Don't forget blood. We love blood.
Oh yeah, just delicious all around. Anyway, we'd love to give a thank you to Tyler for joining us and for being part of the podcast this week. Just appreciate you being a special guest and giving us that moment together to talk with Blair about things that are completely out of my realm. So,
absolutely. It was a lot of fun. Be happy to come back anytime.
Just to talk about more.
Yeah, thanks, Tyler.
Yeah, no worries.
And as always, you can feel free to send us any questions, comments, or concerns. You probably have a lot after this one. You can email us at mediocrecontentpodcast@gmail.com, or of course tweet us at mediocresquawks. Blair, do you got anything else for the peoples?
No, thank you guys for hanging in there with us. We appreciate that, you're willing to hear us talk about these things. And I promise the next episode will be much less gross and much more family friendly.
That's right. It is our holiday special, so please be sure to tune in 2 weeks. And with that, I guess we'll see you guys next time.
Cheers.